So now it gives me enormous pleasure to introduce the first of our two main speakers, Dr. Claire Carswell. Claire has travelled all the way down from York this morning to be with us, where she's an advanced research fellow with the National Institute for Health and Care Research and a registered mental health nurse based at the University of York in the Mental Health and Addictions Research Group. I'm going to leave it to Claire to talk about what her research focuses on and what she's going to talk about with us today, but I'm really delighted she's here. And just before I invite Claire up, there's going to be an opportunity for questions and answers afterwards, and you can do that in a couple of ways. There's a bit of technology involved, so forgive me that I'm not going to explain this very well, but there's something called Slido. And on your table is instructions on how to use it, where you can put your questions for either Claire or our second speaker, or you can hold on to your questions and use the roving mic. So whatever is your preference. I know which mine is because I'm not good with technology, but I'd encourage you to use the Slido if you're doing it. Martin, my comms person, is now giving me the thumbs up that I've said that correctly. But I'm going to hand over to Claire now. So please give Claire a warm welcome.
Hello, everyone. Thank you so much for having me here today. As I was introduced, my background is in mental health nursing. So I previously, if you can't tell from my accent, lived in Belfast. And I worked in sort of voluntary sector organisations, including supported housing, day centres, and obviously had experience on the wards. So being here today feels very, very special. So thank you. So my research is mostly focused on mental and physical multimorbidity, with a particular interest personally in kidney disease and mental health, but I'm not going to focus too much on the kidneys today. And I'm a mixed methodologist, which means that I use multiple different research methods to explore these issues, but mostly I'm going to be talking about the qualitative research that I've done with multiple different research groups. And I'm aware that we've already covered some of the mortality gap in Lee's presentation, so I'll try not to be too repetitive. So, as you're probably very aware, the mortality gap is a phenomenon experienced by people who have severe and enduring mental illness. That means that they die on average 15 to 20 years earlier than people who do not have a severe mental illness. Now, I do want to clarify what I mean by severe mental illness whenever I use it in reference to the research that I'm going to discuss. Mostly what I'm referring to are conditions like schizophrenia, schizoaffective disorder, bipolar disorder, severe depression, conditions that can present with psychosis. But I want to emphasize that any mental health condition can be severe. Any mental health condition can have an impact on quality of life and life expectancy. And this is not intended to be a value judgment on the severity of other mental health conditions. It's just the terminology that we use in research to refer to this group of conditions that happen to have a common set of risk factors. So people who have severe mental illness experience significant health inequalities. They're far more likely to die earlier. And while some of that is because of issues such as suicide or violent and accidental deaths, the predominant driving factor behind that is the physical health of people with severe mental illness. People who have severe mental illness are far more likely to have and develop long-term conditions, and they're far more likely to have complications and to die earlier from those conditions. So, for example, people with severe mental illness are 2 to 3 times more likely to have type 2 diabetes than people without severe mental illness. I've just finished a meta-analysis looking at kidney disease, which found that people with severe mental illness are 2.2 times higher likelihood of having kidney disease. And as Lee's presentation pointed out, respiratory conditions are also much more common, and cardiovascular disease is also much more common among people with severe mental illness. And cardiovascular mortality is actually the leading cause of death among people with conditions like schizophrenia. So why does this happen? What is causing the mortality gap and what is widening the mortality gap? Admittedly, it's a very complicated picture. It's very enmeshed and interactive. However, I tend to, whenever I'm trying to explain it, I break it down into 3 sort of different levels: individual factors, health systems factors, and societal factors. This is an oversimplification, but in general, it's a good way to picture it. I only have 20 minutes here today, so I'm just going to talk about the individual factors and the health systems factors, just to save time. So with individual factors, I think the most common issue that people experience is the actual symptoms of severe mental illness. People are experiencing profound symptom burden, including things like mood episodes like mania and depression, psychosis, that makes it very difficult for people to not only just engage in behaviours that will improve their health, but also might mean that they engage in behaviours that are damaging to their health. So, for example, this healthcare professional from one of our qualitative research projects pointed out that it was a patient with schizophrenia who had real problems with partly cultural beliefs, but also auditory hallucinations telling them not to take the medication. It's poison, and it doesn't help that the nurse that comes is trying to poison you. So there's an actual profound barrier to engaging in behaviours that are going to help your physical health and your mental health whenever you're experiencing severe mental illness. But it's not just the symptoms of severe mental illness themselves, but also the fact that people are trying to cope with these symptoms. And from the research that we've done with a project called Diamonds, what we find is that people with severe mental illness they need to prioritize coping in the immediate moment with those symptoms of severe mental illness, with the hallucinations, with the anxiety and the paranoia and the fear, instead of prioritizing their long-term physical health. So this might mean that they resort to behaviors that we typically associate with per health behaviors, but ultimately they're engaging in those behaviors to help them cope with their mental health. So for example, this service user said that I drink every day, and depending how my mental health is especially, it depends on, how much I'm drinking. So when things are better, I sort of have like a measured amount, whereas when things are not good, it's just escapism really. And it can be quite difficult to motivate people to change that behaviour whenever we don't have an equally effective alternative coping strategy to provide them. So this carer, for example, pointed out in relation to smoking that if she doesn't smoke, she'd be even worse. We had a situation when she was in the doctor's. She had one of these attacks, and she was in a state at the doctor's, and even the doctor came and lit a cigarette for her, which calmed her down. So smoking is actually medicinal rather than anything else. So these coping strategies can be the core to actually keeping people mentally well in the moment, particularly in moments of crisis. And I think that it would be doing a disservice to people if we didn't recognise the impact that psychiatric medication can have on the physical health of people with severe mental illness. I do want to clarify that psychiatric medication is life-saving. It can radically improve people's quality of life. It can radically improve their symptoms of severe mental illness. And as I've mentioned, in qualitative research, what we find is that people with severe mental illness prioritise looking after their mental health over their physical health. But psychiatric medications are also associated with a whole host of really profound physical side effects. For example, antipsychotic medications, and the most recent type of antipsychotic medications are associated with quite severe metabolic derangement, meaning people are far more likely to develop type 2 diabetes, they're far more likely to gain weight, they're far more likely to have high blood triglyceride levels. And that's just a consequence of the medication itself. And then you have other medications such as mood stabilizers like lithium that have a profoundly negative impact on organ systems like the kidneys, which obviously I am particularly interested in. But it is this constant weighing up of cost benefit where people are trying to juggle the improvements that they're experiencing with their mental health with the physical consequences of the medication that they are on. So, for example, this healthcare professional, this is a piece of research that we did looking at renal healthcare professionals specifically, so kidney professionals. They said there's some patients for whom lithium, which is a mood stabilizer that's incredibly effective, is the only medication that works, and you're making a cost-benefit consideration in terms of transplanting somebody on lithium and knowing the lithium may have an impact on their new kidney, but yet in terms of their mental state, the risk-benefit ratio is worth them staying on lithium. And I can say from my experience with my PhD, which I worked on a dialysis unit during that time, one of the patients that I worked with had to come off lithium in order to start dialysis. And she was far more scared of coming off lithium than she was starting dialysis because of how well she had been for so long. So this is really a very serious risk-benefit balance that people are trying to strike. So those are the individual factors, but I want to kind of focus on the health systems factors, because these are the issues that tend to come out whenever we are working with our patient and public involvement groups with our research. So we work very closely with service users and with carers to sort of generate our research questions, but also design how we're going to recruit participants and things like that. And what comes out repeatedly is that the barriers to really improving physical health tend to exist quite significantly in the healthcare system. And something that's already been talked about is the fact that our services in the National Health Service are very fragmented. They operate within silos. You see specialisms, which obviously are necessary because people cannot be experts in the entire human body and mental health as well. But it means that people aren't being treated as whole human beings across services, and these services also aren't communicating very effectively with each other. So, for example, this healthcare professional said, I think this was a nephrologist actually, I think when it comes to mental health stuff, though, we sort of hold our hands up. It's almost like dentistry. We are never going near the mouth. That's just cordoned off. We respond in a similar way to psychiatric stuff, which ultimately does a disservice to patients and service users, because you don't present to, say, a kidney professional with only kidney issues. You're also living with your entire body and your entire mind. So this is a serious issue whenever it comes to actually having joint up services and stopping patients from slipping between the cracks. I do want to emphasise, though, that this is then compounded by the lack of resources, funding and staffing within National Health Services. There is a lack of resources in the NHS at the moment, and that translates into limited time and limited energy among healthcare professionals. So, for example, this service user said, I can't spend all this time on you. You're not the only person here. But what they don't understand is my hyper-anxiety. I have a sensitized system. So anxiety to me is, compared to you, it's completely different. I'm not resilient in the same way. So I need that extra time to have things explained to me. It's not my fault. And I think that that's where people with severe mental illness and other sort of complexities can really fall through the cracks, and that they do need extra time, they do need extra patience in order to receive an equitable level of care from healthcare professionals. And this then translates into inadequate policies. And one policy in particular that I've encountered both in clinical practice and through the research that we've done is this sort of 3 strikes and you're out policy in outpatient services or in primary care services, where people are taken off the books of, say, a specialist service or a GP if they don't attend for specific appointments. And that is, again, particularly disadvantages people with severe mental illness who may struggle to attend appointments for a whole variety of reasons, including managing the symptoms of their severe mental illness, maybe feeling paranoia and fear and not wanting to leave the house, or maybe they've experienced quite traumatic treatment in mental health services that generalise to physical health services, so things like detention or forced medication, and that makes it far more difficult to attend appointments, and then people can also struggle to access social support to attend appointments or even access transportation to attend appointments. So, for example, this healthcare professional said, sometimes they can't engage with these appointments if they have got a chaotic lifestyle. So they might miss appointments and then there's no sort of follow-up for that. So they miss out on appointments or investigations. And again, they fall through the cracks. And I think that there is this emphasis at the moment in healthcare services and a lot in research as well of sort of screening people, doing the health checks. But the issue comes whenever something is identified, and then whenever people are trying to access specialist services, they're getting taken off the books because they're struggling to attend those appointments. So there's a bottleneck there between screening and intervening. And then finally, I want to talk about diagnostic overshadowing. You might have heard this term before, but basically this is whenever someone presents to, for example, A&E or their GP with a physical health symptom, a physical health problem, and they also have a mental health condition. And the healthcare professional who is treating them sees that diagnosis of a mental health condition and then attributes those physical symptoms to that mental health condition and doesn't do proper assessment or evaluation, doesn't refer them on for better investigations, or doesn't provide them with treatment. And this is particularly irritating to me because it is the opposite of evidence-based practice. We know if someone is coming to a GP or an A&E or an out-of-hours service and they are presenting with a physical health issue and they have a severe mental illness, statistically speaking, they're very likely to have a long-term condition, and they're far more likely to be further progressed in that long-term condition than someone without a severe mental illness. So this is fundamentally about stigma. And this service user, for example, said, as soon as they read the list of scripts, I could see that it predisposed them towards almost a Munchausen sense of the patient in the bed, as needy and difficult and demanding and contrary. And this does come from stigma. I actually have just come back from a conference in Portugal, which was a kidney disease conference with mostly kidney nurses. And I was presenting about severe mental illness and the risk of kidney disease and lack of access to things like nephrology services and transplantation. And one of the nurses asked me a question that literally had my jaw on the floor. But she asked me whether or not it was ethical to provide life-saving services like transplantation to people with severe mental illness if they do not lead fulfilling lives. And it was like, absolutely. Thankfully, I wasn't the only person who was shocked by this question, but someone should have taken a picture of my face at the time because it was jaw on the floor. But that's the level of stigma, where people who are trained maybe in other specialisms don't have this understanding of severe mental illness and the impact that it has, and the fact that people are just people and everyone deserves to live a fulfilling life. So we do still have work to do in terms of stigma, including in healthcare services itself. So I'm aware that everything I just discussed is incredibly bleak and quite disheartening. So I want to talk about how we can better support people with severe mental illness manage their physical health. And there has been a lot of research in this area. So previously, I worked for the Diamonds program, which is looking at supporting self-management for people with severe mental illness and type 2 diabetes. And there are other self-management programs that have been evaluated, like Primrose, which was looking at cardiovascular risk and severe mental illness, Scimitar, that was looking at smoking cessation, and Stepwise, that was looking at weight loss. And the real focus of these interventions have been to support people to make changes in their day-to-day life and manage their physical health themselves. So it does put a lot of emphasis on the individual, on their autonomy, and their ability to look after their own health. We haven't got the results from the Diamonds program yet, so we don't know if it's going to be effective, but we have got the results from the Primrose and the Stepwise programs, and both of them were shown not to be effective. And I think that there's an important question here about whether or not self-management is where we should be focusing, at least within research. With the Diamonds program, for example, we have co-designed this intervention with service users and carers and healthcare professionals. And the more we tweak it, the more support we add. So at the moment, it is a 6-month-long program with weekly one-to-one sessions with a coach, as well as with the person having a workbook and an app. So it's very, very supported, and it's very highly reviewed among participants. We just haven't seen if it's effective yet. So that's moving away realistically from self-management and more about providing intensive support for people. And one thing that I've noticed from the qualitative research that we've done, as well as the PPI work that we've done, is that self-management doesn't seem to really be where service users and carers want the focus to be. They want the healthcare system to be easier to navigate. They want the healthcare system to be more integrated and joined up. This focus on individual responsibility isn't taking into consideration the complexities of living with multiple conditions, particularly with a severe mental illness. And the standardized approach to care, where it is a blanket approach where everyone receives the same sort of standard, might be efficient and might be a cost-effective way to run the NIHR, but it means that people aren't receiving person-centred care and they're falling through the gaps whenever they're experiencing complexity. So I think what we need to do is essentially design better healthcare services or adapt our healthcare services to be far more person-centred and to focus more on the patient and the service user. And I just want to end with this quote from a mental health professional from, it was Clodagh Cogley's work, so this was a colleague at UCD, who said, we need to think, what is the target population we're looking at? How can we design it around that person and their needs? Because most healthcare systems are built around the professionals' needs, not the patients. And the patient should be at the centre of healthcare services. Thank you very much for listening.